Afternoon, everybody. My name's Geen. I'm a consultant clinical scientist and also the Assistant Director for Research and Development for Morgannwg University Health Board. So thank you for signing up to today's session. It's a workshop session on the role or the putting research into practice for AHPs and healthcare scientists. And there'd be lots of scope today for some chat and for some discussion. If you feel you want to actually say something verbally and not write it in the chat, you're more than happy to put your hand up, and Ellie, who's our facilitator today, can give you access so that you can speak. So the form this is going to take is that I'll give an overview of research from my perspective as a healthcare scientist, and then we'll go on into a proper workshop session where we can discuss a couple of questions that I've got for us as healthcare professionals with our approach to research, and now we can help put research into practice as professional healthcare AHPs and healthcare scientists. So Ellie, if you could start the presentation, I'd be really grateful. Right then, folks. So that's me. That was my brief for today: putting research into practice for AHPs and health scientists. Next slide, please, Ellie. So, what is research? Next slide, please. So, research comprises a creative and systematic approach to establish new knowledge through proven methodological processes and techniques. And research can be broken down into two basic areas. One is basic research and one is applied research. And being a laboratory scientist, myself and colleagues, we do get involved in basic research, but within the NHS, I think it's really important that we all try and undertake as much applied research as we possibly can to benefit the patients. So applied research, it usually follows basic research. So that's research that's come from the bench, or from a classroom, or from a concept or a theory or an idea. And then with applied research, there's attempts to determine and exploit the potential of scientific discoveries or improvements in technology, materials, processes, methods, devices, or techniques for use in a new application. And with our line of work, that's very often associated with patient care. Not always. It can be in, it might be in staffing and work and staff well-being. Perhaps if you're a psychologist. But much of the applied research we do tends to have an impact on patient care. And applied research also attempts to advance the state of the art. So we don't stand still. We can use research to move forward. And once you undertake some research, apply it, there's usually other questions that follow that require further research, and it develops a continued benefit to that patient ongoing. Next slide, please, Ellie. So there's two well-described schools of thought on new knowledge. One was facts are meaningless. You could use facts to prove anything that's even remotely true. That's a quotation from Homer Simpson. And there's a quotation from Anton Chekhov, which is, knowledge is of no value unless you put it into practice. Now, I favor Anton Chekhov's. I think it's a bit more of a positive approach to research and establishing new knowledge. And much of what we do should be based on what he says rather than what Homer says. Next slide, please, Ellie. So why should we do research in the NHS? Next slide. There's lots of reasons, all positive. Research can definitely inform evidence and a value-based change in behaviours or patient care, service improvement, efficiencies and outcomes, can improve access of patients to new therapies and technologies and treatments, which is essential, particularly for those those patients who may have conditions that there is very few options in terms of treatment and management. So when new options come along, it's only fair that they should get access to those new therapies through research and see if they are beneficial for them and others with the disease. Research can provide a robust investigation of efficacy and effectiveness of any intervention. That may be a therapy, it may be a medication, it may be a device. Research can facilitate career development, job satisfaction, and it's one of the 4 pillars of professional practice for NHS staff, particularly those with band 7 and above. We should all be doing research. It improves recruitment and retention of the highest caliber staff into an organisation if they've got access to research and research facilities and research opportunities. It can lead to academic and industry partnerships and collaborations. It can increase income generation, and that can be through Welsh Government funding or grant funding, commercial research income, and sometimes commercialisation of protected ideas, concepts, projects and devices that have gone through a rigorous research process and shown their worth. Research can contribute to the corporate and social responsibilities of the NHS. We're not just about health in the NHS. We need to look after our population as a whole. So that does include their wealth and their well-being. And by wealth, a particular research study may involve the invention and research of a widget that may be could be manufactured in the locality and provide jobs for the population. And high quality jobs is high quality salaries, which leads to high quality, better qualities of life, and that could stem from research. And I'm not sure whether you all know that it's been proven beyond doubt that research active clinical organizations have superior outcomes in terms of patient morbidity and mortality. And that's not necessarily just through the direct impact of research per se, but also those organizations that have very active research agendas and ambitions, they just seem to be better prepared and are in a better position to treat their patients, manage their patients and their population with better outcomes, as I've described, in morbidity and mortality. Next slide, please, Ellie. Also, why should we do research? It's becoming really important now in lots of national and international strategies, particularly around health. The future of UK clinical research delivery, it's a very important document. I would advise you all have a read through that. It's not too difficult to read. It's very strategic, and it puts research on the map with regards to NHS, both its staff and how we can better serve patients through research. Also, the Welsh Government's own Healthier Wales strategy, the strategy for the next 10 years for the NHS. Research is mentioned throughout that document, which was very pleasing to see, where they recognise the importance of research for patient care, but also for staff development and making sure that staff they can gain job satisfaction from their clinical practice, but also from changing clinical practice, and that will require research. And a new strategy that's come out on Welsh Value and Health Centre. It's that has also got a lot of research dotted throughout that strategy, where it provides the evidence that research is vital if we want to develop a value-based approach to healthcare delivery in Wales. Next slide, please, Ellie. On a more professional level, and this is what this conference is about, and this session is about, the healthcare scientists in Wales have written and published a framework with the support of Welsh Government, and as have AHP colleagues with their framework. And once again, research is explicitly mentioned in these strategies as key areas and key factors that as healthcare scientists and AHPs, we should be delivering on to help change the NHS for the better and obviously have that beneficial impact on our patients. So, there is an opportunity perhaps for this session to learn from the current best practice and we can develop new ways to encourage and enable, undertake and succeed in high quality applied research. Thanks, Ellie. So strategically, it's really important that we do look at research and the next two slides, this slide is basically just cut and pasted from the Healthcare Science Framework in Wales, just to demonstrate what performance targets or ambitions we've set ourselves to try to achieve to help deliver the research aspect of that framework. So it's a large program of work, but hopefully at the end of it, all those ambitions will be met. Next slide, please, Ellie. And for this slide, I've gone through the AHP framework for Wales, and I've essentially cut and pasted a lot of the sentiment, but also their program of work that's dotted throughout the document on how they want to encourage and support research activity and research opportunities for AHPs. So that was also really pleasing to see that essentially in Wales, in the NHS, we're taking it very seriously, that research is critical for developing the services of the future. Next slide, please, Ellie. So that was why do we do research? The next question we've got to ask ourselves is, where should we do research in the NHS? Next slide, please, Ellie. Everywhere. That's the truth of the matter. We should be doing research every opportunity we get in the NHS and social care, particularly the integrated care models now between healthcare and social care. But there's major areas that jump out at me. One is primary care. We need to do more research in primary care. We need to do more research in public health, or population health, as we should call it. Big data. I have an interest in big data myself and primary care research, secondary care research, and obviously social care research. So there's no bounds, really. We should all be doing it together in all aspects of any care delivery, whether it's healthcare or social care. Thank you, Ellie. Next slide. Who should do research in the NHS? Next slide, please, Ellie. Everyone. We all should be doing research. Research, it should be a core function of all staff. And I don't just mean the clinical professionals, like the scientists or AHPs, pharmacists, it's everybody. Management should be doing it, in my view, and all grades of staff should be doing it. Some of the lower grade staff, they can come up, they're on the shop floor as well, and they often come up with problems that need resolution, and resolution can often trigger a research idea to find the evidence base to make sure that the solution to a problem actually fits. So everybody should be doing research in the NHS. Next slide, please, Ellie. So for this session today, I basically set ourselves some questions on to try and help us answer the question that I was set today, putting research into practice for AHPs and health scientists. So I was hoping that we could share, first of all, could we share some examples of AHPs and healthcare scientists NHS research activity and where you've put research into practice? Secondly, so you can start thinking about these questions, how can AHPs and healthcare scientists be involved in NHS research? Thirdly, what are the facilitators for AHPs and healthcare scientists to contribute to research in the NHS? I've deliberately mentioned facilitators there rather than the barriers. I think we all know the barriers, so I thought it might be better to focus on the positive and just try and see if we can help ourselves in facilitating our own research as AHPs and healthcare scientists. And finally, what are the opportunities for AHPs and healthcare scientists to contribute to research in the NHS? And leave me with my R&D leadership role. There's loads of opportunities. I'm just mindful that sometimes not everybody may know about those opportunities. Right, next slide, please, Ellie. Right, so sharing examples of AHPs and healthcare scientists, NHS research activity, and putting research into practice. I was just wondering if, I don't know, it's going to be a difficult ask for you to type something, but if you want to put your hand up, you can put your hand up if you're prepared to say perhaps some of the work that you've been doing yourself as an inspiration to people who are on this session. Is anybody prepared to put their hand up? Because if you put your hand up, Ellie can bring you in then for you to talk. Is anybody happy to do that? I'm just reading some of the chat down the side as well. So Robert's put some chat there from Cardiff. Thanks, Robert. Oh, Robert, yeah. So Ellie, Robert wants to come in, I think. He's... Robert, I think you're live.
Hello, can you hear me?
Yeah, I can hear you.
Great. Yeah, so I can talk about one of the projects we did in Cardiff where we did a small qualitative piece of work looking at a problem we could see clinically with people with sciatica. So just to really document what we were seeing. And that's led to a lot more focus from the whole health board on trying to answer that problem and meet the needs of those patients. So that's led to a reorganization of a pathway for us to prioritize care and deliver better care. And for me, that's from a very small piece of funding from RCBC, that's demonstrated we can influence the real world practice.
Brilliant, Robert. That's a really good example. I'm guessing you're a physiotherapist?
Correct, yeah.
Yeah, well, that's exactly what we need to be doing. So yeah, I'd like to congratulate you on that. That sounds a really good piece of research there. So well done. I nobody's put anything else in the chat at the moment. Oh, Sarah. Hi, Sarah.
Hi, can you hear me?
I can.
Fantastic. I've got two examples, if I may, John. So one is my own research. I had a clinical hunch quite a while ago that people living with dementia that were coming through to us with hearing loss weren't just more commonly experiencing hearing loss, but they're experiencing it a little bit differently. Lots of people struggling with hearing aids, lots of people struggling with background noise, but also the reactions they were having were a lot stronger than we normally experience, and motivations were slightly different as well. So I managed to get an NHS Clinical Research Time Award to develop a little bit of underpinning theory through a scoping review, and that's now been taken forward with a KES Research Masters. Hopefully somebody will be able to go on to interviews and focus groups to explore that and turn that into some substantial evidence. But because it was an NHS Clinical Research Time Award, it also gave me the kind of capacity and networking support to push the kind of the general hearing and dementia agenda. So over the 3 years, we were able to get resources for setting up some new hearing assessment pathway as part of the dementia assessment processes in North Wales, and that's now been rolled out in the whole of North Wales. So there was a nice sort of clinical byproduct along the way as well. And then a second example, if I may, that I think was a nice illustration of the system is there if you can just figure it out. So we had somebody, again, a clinician, who was interested supporting people living with tinnitus and doing rehab with them. But realised that we didn't really have a great understanding of what to do when somebody had normal hearing and tinnitus. Very practiced when they've got hearing loss as well, but if they had normal hearing, what do we do? You know, is a hearing aid still something that's helpful with a bit of white noise on it to distract? And so she applied for a First into Research, the programme award, and actually ended up not being eligible for that one, but then just used the same application on the Pathway to Portfolio and was successful. And so managed to do Pathway to Portfolio and has now been awarded with an RFPPB big scale amount of funding, and is doing that with another 2 audiology centres in Wales. So it's basically a pan-Wales portfolio level research project to do an RCT of the benefit of hearing aids for people who don't have hearing problems but do have tinnitus. And I think it's taken us a long time to figure out that there are other ways to get those larger pots of money. You do just need to start small, start with your First into Research or your Pathway to Portfolio, or if you've done research before, start with a Research Time Award, and then kind of build up from there, really do the groundwork first. And that was after many, many years and many Christmases lost of applying for the big pots straight away and not getting anywhere.
Yeah, thanks, Sarah. Yeah, 2 really good examples there. So, you know, Robert's given a really good example of a therapist. You've given a good example of 2 excellent projects also, with which is scientist-led, which is fantastic. So, you know, you've shown that it can be done, and you know, I am aware of lots of other examples, lots of you know, occupational health in my own organisation. We've supported an occupational health therapist to do her work and complete a PhD. She's writing it up now. I know we also have an audiologist with Dr. Jonathan Arthur, who did an excellent PhD, which was supported within the health board, on the social and psychological aspects of hearing aids. So there's some really, really good examples. I know they're out there, and I'm aware of a physiotherapist with us at the moment, Helen Welsh, is just started a PhD as well. So it can be done. It can be done. So thank you for sharing those examples, and hopefully that's just provided a little bit of inspiration to others on the session today, that it can be done and it can be achieved, but there is support out there. And Sarah's last few sentences leads us on quite well to the second question. Can you put the next slide up, please, Ellie? So how can AHPs and healthcare scientists be involved in NHS research? So I think Robert and Sarah have given really good examples how they've done their own research with their teams, and worked collaboratively, which is always a positive. Now, has anybody got any other ideas how you could become involved in research? And I'm asking that more as the R&D lead more than a healthcare scientist. I'm never sure that people are actually fully aware of how they can become involved in research. Is anybody prepared to either come on the chat or verbally, or type it in as a post? I'll give you a couple of seconds to think about that. Hiya, John. What's your background, John, first?
Hi, I'm a physiotherapist and work in CUMTAF. I've got a split clinical and research role in CUMTAF, but I'm still a research novice. I just wanted to share a piece that I completed. It was a few years ago, but it taught me a lesson. It was essentially, we had a question that we wanted the answer to, and it was whether it was regarding the experiences of physiotherapy undergraduates in their clinical placements. It had been standard for us to take 1 student at a time, and we had wondered whether we should be taking 2. There were significant problems with placement provision at the time, and it was it was causing the university problems with the numbers of physiotherapists that they wanted to train because they didn't have access to enough placements. It was felt that having two was much more problematic and would cause a lot of difficulties. So we did a qualitative piece, and it was there was interviews for the students and for the clinical practitioners, and they identified some themes. There was positives to it, and there were some negatives, but they were all quite easily managed. And we presented that, took it to conference, and then I put it away and didn't really think about it again for a while. But I bumped into one of the Cardiff University, the physiotherapy lecturers in Cardiff University recently, and he told me that before we did that piece of work, my colleague and I, there were 4 placements in Wales which took on 2 students at the same time, and the next year there were I think over 60, he said. So he felt that it had an impact, whereas if I hadn't bumped into him, I wouldn't have known that, and it gave me sort of a lift and enthusiasm to think of the next project. So I think the key thing for me with that is that when you've done something, revisit it down the line and just check for impact and see if anything has changed.
Yeah, stay on the line a minute, John, because obviously I know you. But what about, that was another really good example, and you do raise a good point there, that as healthcare scientists and AHPs, we often do very good pieces of work, and 1, we're guilty of not following them up and seeing the impact, and 2, we're guilty of not actually telling everybody that we've done a good piece of work, and that's a skill we've definitely got to learn. There's no harm in shouting from the rooftops if you've done a really good piece of work. But can I ask you, could you just talk to the group about your experiences of supporting other people's research that is on the portfolio? Because I know that you do that as well.
Yes, I'm a novice at that. I've only been in this role for a few months, but on the portfolio, I suppose my experience of those is, like I said, limited because I'm a novice. I think the portfolios, they're bigger pieces of work. There's a lot of detail to them. It's working out the methodology and just, I suppose, the fundamentals, excluding the bias. I think one of my experiences is, I think generally that people want to help with these projects, whether it's a service evaluation or service improvement or a research portfolio, is that the absolute majority of NHS staff want to help and want to help drive this forwards. So in terms of, I know other people have asked about how do we sort of engage and embed a research culture. I think a lot of it is just harnessing and allowing people's enthusiasm, and letting them get engaged with these. And some of that's time, some of it's headspace, some of it's permission to do it. But that's the thing that struck me, is the enthusiasm and people wanting to get involved, when on the face of it, there's very little in it for them. There's just more work and responsibility, but people want to get involved.
So you raised some good points there, John, and for the rest of the session, the group who are listening in now, it's a good way. It's a good route into research, isn't it? Where you can actually support other people's research that is high quality and on the portfolio. And that might be in selecting patients. It might be recruiting patients. You might actually be involved in undertaking the intervention, mightn't you? So yeah. How do you feel that, I've done that myself, and I'm just glad to be part of the research. I don't necessarily always want my name on the paper. How do you feel?
Yeah, it's nice to be involved with something. I totally take your point that they feel like big projects, and I don't feel, as a novice researcher, I don't feel that I'd be able to organize something like one of these RCTs on that scale. But as you say, it's a real learning experience to be involved with it and talking to these people and getting familiar with the language and the processes and and the legalities and the governance around these projects. So that's been really exciting and really interesting, and I'm really happy to be a part of that. And as you said, quite a few of these things were actually involved in either being the trial research clinicians and collecting the data, and other clinicians are delivering the intervention, or actually delivering the intervention in these cases.
I'll put you on the spot now, John, and this is for the benefit of everybody else. And that's so but I understand that you're also looking at the portfolio yourself now to see if there's other studies that we could open in your organisation.
Yes. I'll give myself an hour or so every few weeks and start and pick through and see if there's any that we can do, and then I work with the R&D team, and they'll approach the CIs and see if they're still open for recruitment. We've picked up one through that, and that was a qualitative piece about the novel use of robotics in pediatric rehabilitation of children with CP. And so we've got that one, and that one's on. And there's another one we've picked up recently, which is interesting, and it's definitely worth scoping out. We're waiting for that. We've also I've also been working with Cardiff University and building links with the academics over there, some of whom the previous speaker Rob and I know from our days in Cardiff, and that's Kate Button, Mohammed Al-Hambri, and they are very interested in recruiting from our patients, and there's some really interesting projects there as well with the physiotherapy bias, which a lot of those fit in with some of the themes that have come up in the morning sessions about promoting self-management and more independence. So yeah, there's some really interesting opportunities out there.
I suppose the point I'm trying to emphasize really is that, you know, you describe yourself as a research novice. I don't think you are really. You're not that of a novice when you've done some research yourself, but now you are supporting the larger national, international portfolio studies. You know, that's really good. But already you can see that it's generated more research activity for you straight away.
Yes.
And so it's almost taking the first step, isn't it? When AHPs and healthcare scientists want to be involved in research, it's sometimes we've got to go out there and look for it ourselves, and ask the R&D departments what's on the portfolio in my area of expertise.
Yes, I think as soon as we were starting to, you know, someone like me had some more time to build these networks and build these links and have these conversations, the academics have projects with funding that they want to recruit for. You know, it's a symbiotic relationship. We want to do it, they want to do it. We, as you said earlier, we know that we'll get benefits from engaging in this research, and there's correlations between the number of patients that you recruit to research projects and the outcomes that we have for our patients who use our services, which is fundamentally the thing that we all have in common. We all want better services, better outcomes for our patients. So if by engaging in research we're working towards that, then again, everyone's on board with that. And that's one of the joys of working in the NHS. We all have fundamentally the same drivers.
Yeah. So, and I'd also like for this question, I think it's important to highlight that people like yourself, John, and even myself in my early research career, you know, you start off as a supporting agent or officer, really. But I can see you already, you know, people like you and Robert and Sarah and other people on this session, you will, you know, you'll be able to be PIs for studies where you're the principal investigator for the organisation. There's no reason why you can't be. And then eventually, you know, you could even be a CI, the chief investigator, with a full responsibility for research studies in your specialty. So it doesn't always stop just at supporting other people's research. You can support other people's research, but with a degree of responsibility for that study within your organisation as well, with the support and guidance of the R&D teams. So thanks, John, that you really helped with the discussion there. That was really, really helpful.
Thank you.
So hopefully with John's contribution there, we've persuaded you that we AHPs and healthcare scientists can get involved in research. It doesn't always have to be our own research. There's thousands of projects out there, and there could be a project in speech and language therapy. It might be a swallowing project, or dysphagia, or where you might have a degree of expertise. If you ask the R&D department if there's any such projects on the portfolio, we can look to open them. And if we open them, you could be PI, and we'll look to support you through that project process. And resources dependent, we can help support you with the recruitment at clinics or on wards. So you're never on your own. Next slide, please, Ellie. So then this question, as I've said, I've kind of focused on the positive here. What do you think of the facilitators for AHPs and healthcare scientists to contribute to research in the NHS? I think one of the key facilitators has been already well demonstrated by Robert, Sarah, and John. And that's just having an enthusiasm for research. And sometimes you do have to drive it yourself. That is a key facilitator. One is having the interest, two is having the enthusiasm, and three is probably having the motivation and perhaps commitment to try and undertake research or support research on top of your day job. Now, that is not easy, and I appreciate that's not easy, but it can be doable. It can be doable. So does anybody else want to chip in and perhaps give some ideas on what they think would facilitate research, or AHPs and healthcare scientists undertaking more research in the NHS? Does anybody want to put their hand up or write something in the chat? Or Chris?
Hello. We've always supported the local university in terms of projects, and a great advantage of that is the previous student is now working for BCU, so there's that benefit in that some of the very good students then become staff.
What's your background, Chris? What's your specialty?
In respiratory. So I'm originally from sports science background.
So you're a respiratory physiologist?
Yeah, respiratory physiologist.
Mm.
I meant to come in a bit earlier. It's just I had an internet connection problem. So.
No, that's really good. So a facilitator, you're saying, is probably, it's good networking, is it, with the HEIs particularly?
Yes, yeah, and by networking with the local university, I've also used had like supporting letters from the university with other bids for equipment, and have found that's helped my case, to develop equipment as well in the department. So it's a larger scope than even just a research profile. It also helps with other bids as well.
Mm. Yeah, so that's actually would be on my list, Chris, is networking, particularly with HEIs. Other people that you may wish to network with, industry can be very helpful. I've undertaken a few projects myself where industry will approach me and say, we've got this new device, clinical biochemistry device. It measures serum rhubarb. Are you happy to get involved in some research? And we do. And I think there's opportunities in all our professions that industry can approach us and do approach us, because they do need access to patients to test these devices, don't they?
Yes, yeah.
So I think industry is a good way. The only thing you've got to be mindful of is that just make sure that everything goes through the governance and your R&D teams, and that it's not you're not just doing it to benefit the industry partner themselves directly. They will benefit from it, but I tend to do research where I think that it will. There's a potential for it to also benefit the patients as well as the industry partner, and that the NHS's contribution is recognised as well in anything that they publish. What about? This is not specifically even you now, Chris. I can see you're still on, but
yeah, I'll just go in now.
Okay, thanks, Chris. How do you all feel? How many of you have actually spoken to your R&D departments and sought advice from them? There's no hands at present. There's nothing in the chat. This is a shout out to the R&D teams across all the NHS organisations, just to say that they are really a fantastic resource for facilitating research. They can help you with your ethics applications. They can help you with the study design. They can help you with your grant applications, whether it's costing them up. They can help you complete them, make sure all the finances are in order. So just to make sure that you are actually asking for the right amount of money and you don't leave yourself short. They can put you in touch with collaborators that we usually already know have an interest in that field, and it could be the same field that you're looking to do some research into. So I'd just like to say that as a facilitator, the NHS R&D departments are essential. The skills they've got are fantastic, and they are very, very knowledgeable on all aspects of research. So I would always ask you, always talk to your R&D teams. They're there to help, and they want to help you with your research, whether it's supporting other people's research or undertaking your own. I think the other main facilitator would be time. I think there are posts out there that are joint posts. John's just come online now from my own organisation, where we've got a split post with funding for him and the physiotherapy department. We have within clinical biochemistry as well, we have a joint post with Dr. Alan Dodd, who's a postdoc. He does research, but he's also a clinical scientist. And we've supported occupational therapy in the past and speech and language therapists in the past. So there is an opportunity for people to gain some time to be able to support research, but it does require time and it does require funding. But there's no harm in you. Oh, how have we managed to joint split posts? Thanks, Sarah. Just through recognizing the skill set that we've got with our pharmacists. We fund pharmacists, we fund some therapists, we fund scientists within my own organization. It might help because I'm a scientist and I'm the R&D lead as well. But it's just through recognizing that there's lots of research out there that requires these specialist skills to help recruit into studies, whether it's a physiotherapy study or an audiology study or a biochemistry or point of care or pathology based study. So that's enough evidence base to warrant the funding of those posts from the money we get from Welsh Government. Hopefully that answers your question. So, yeah, time and money is important in terms of facilitators and mentorship. So people are often a bit nervous about starting the research journey. But there are, if you go to your R&D department, there are people they can put you in touch with. It could be the R&D directors who can give you advice on your career, and we're all happy to give that advice and be mentors for you, to encourage you to participate in research. And it may start off a lower level, but we would like you all to be PIs and CIs of the future, doing your own research. So mentorship is important, and I would ask you to talk to your R&D teams, or even an ex-HEI mentor that you may have had if you've done your degree, your BSc or your master's degree. They're often useful people to talk to as well. But mentorship is available. And one of the biggest things is for facilitation of research in the NHS is culture. The culture, there's got to be a positive culture and a want to undertake research. And that's got to be at corporate level. So that's from the board and everybody on the board, but also at departmental level. So, line managers, they need to be switched on to it, and they need to be supportive. So if a member of their staff wants to do something, they can support them in their endeavours, their research endeavours. So culture is really, really important. Now, I think we'll go to can you go to the next slide now, please? Ellie? So this is the last slide. We've got about 10 minutes left. So the last slide is, what are the opportunities for AHPs and healthcare scientists to contribute to research in the NHS? There's loads of opportunities out there, and it was really good that a lot of them have been mentioned already by Sarah mentioned a couple. KES, RCBC, First into Research. So there's lots of opportunities out there. It's just that we need to be, as healthcare scientists and AHPs, we need to know what's coming up and what's available, what calls are going out. And I'd like to think that all R&D departments, when a call comes out, they distribute it widely across the whole of the organisation. I know we do in Morgannwg with Rian's help. Rian's the R&D manager, so with her help, we make sure that all really important calls get shared widely across the AHPs, healthcare scientists, medical colleagues, our nursing colleagues and midwifery colleagues, pharmacy. And at the same time as sending an email out that may describe a research opportunity, we also offer our support that if they are interested, they need to talk to the R&D department, and we can help you. So in terms of opportunities, has anybody got a really good example of an opportunity that they've grasped with two hands that hasn't been described so far? Is anybody willing to come on and perhaps give an example of that? So spotting the opportunities can be the tricky thing. Well, being aware of the opportunities is one thing. Then spotting the opportunity is the next thing. And then actually taking up the opportunity is the third thing. And we do need to be taking up these research opportunities. I think we all need to be aware. Kieran's probably spoke to you this morning, Professor Kieran Walsh, the Director of Health and Care Research Wales. And hopefully he's reassured you that there could be more money coming into the pot for research within the NHS in Wales, because the UK government has increased the NHS spending, and part of that will be research. So we're all hoping that there will be more research funding coming in, and that will definitely help increase the research opportunities for us. And that might be the development of clinical academic posts. I know Rob said earlier in one of his posts that the clinical academic posts are few and far between, particularly amongst AHPs and healthcare scientists. And that is a shame, because we've got an awful lot to offer. I think there could be more with the nursing as well, and midwifery. And I think there's not that many with medical colleagues, really, if you look across the border and compare us with England. So that's another opportunity for us. John?
Hello. I was just responding to your call for, has anyone got any examples of looking for research opportunities and then taking them? And if you'd like, I can just briefly share a few of those.
Yes, please.
So in physiotherapy, there's been, especially particularly in musculoskeletal physiotherapy, there's been a lot of change in the way that we deliver services. There's been an exponential growth in these advanced practitioner roles. One of those is what we call first contact practitioners, where typically MSK physios will work in a GP surgery and do GP substitution work. And that's a novel new role. There's a lot of unknowns about it. And one of my colleagues is currently doing a piece where it's a qualitative piece where she's investigating what the GP receptionists think about the service, what their perception of it is, and looking for a thematic analysis of how they feel around it, essentially. Another piece, again, looking at these advanced practitioner roles. Another colleague of mine has been working in A&E for a long period. He in his scope of practice is some patients who've had some certain types of trauma, essentially. So he's completed this and is looking to get it published, hopefully. He's been examining the patient experience of seeing a physiotherapy advanced practitioner rather than an orthopedic doctor. He sort of briefly shared the results with me, and typically people are really satisfied with it. So he has that. A piece that I'm starting to look at the moment is regarding Corda Requina syndrome. There is a lot of literature about this. There's a lot of uncertainty around this. And as we're in MSK physios, we're expanding out of our usual comfort zone. We're having to accept that there is a lot more uncertainty than we previously had to use, that we've been used to in making our diagnoses. One of the things that we typically are most worried about is Corda Requina syndrome, which can have a very vague presentation, but then in the early stages, but then can lead to catastrophic neurological loss relatively rapidly. Part of the accepted approach to this is a safety net, what we call safety net patients. So we give patients information that if you get any of these symptoms, that you then need to go to A&E. However, it's not really known if that's standard practice. There's not clear guidelines that we should be doing it. There's only some pieces of opinion. There's not much consistency around it either. And it's not known what MSK physios, how they actually feel about it. It's not known how patients feel about it either. There are sort of these concerns that by telling people, the majority of whom will just have simple back pain, there's these concerns that if we safety net them and warn them that, look, something catastrophic could go wrong and you'd need to go to A&E instantly. There are arguments that actually you're complicating what is almost certainly just simple back pain. And we know that catastrophizing and worrying about movement are significant prognostic indicators for not recovering well from back pain. So it's a piece where we don't know how patients feel about it. We don't know how MSK physios feel about it. It feels that there's a space there for a qualitative piece. So there's just questions unanswered and opportunities to engage in some research in those areas.
Yeah, and I think that's a really important point. As the scope of practice develops for all of us, we get exposed to patients that perhaps we hadn't previously been exposed to fully. And so that is an opportunity, isn't it, as you said, to undertake your own research, because they're your patient cohort, and you know, it's probably easier to recruit them rather than recruit them on behalf of an orthopedic surgeon. So yeah, that's a really good point. Well made, that is, John. Take the opportunity from any new roles that we've got.
Yeah, and then to expand on that point, one of the portfolio studies that I'm helping with at the moment is it's called an Artisan Study, and it's for looking at physiotherapy rehab after traumatic first-time anterior shoulder dislocation. And it's been very difficult for our T&O consultant colleagues to recruit, primarily because they're so busy in the fracture clinics. But as you said there, we have a physiotherapist in an advanced role working with shoulder clinic, and that's been our route to be able to start recruiting these patients through there. So you're right, it gives us opportunities being in these different roles and having these advanced practice roles becoming more and more common.
Yeah, thanks, John. That's really helpful. Other opportunities, you know, we should be maximizing. You know, is applying for the fellowship roles. You know, there's lots of fellowships offered, whether it's MRC or the Wellcome Trust, Cancer Research UK, British Heart Foundation. You know, they're not always medically based. They are often open to any healthcare professional, and I think we should be we should have the confidence to apply for some of these fellowships ourselves as healthcare professionals. There are some very good schemes in Wales. Say Sarah's mentioned a couple already. The Clinical Research Time, or Research Time Award now as it's called, they've actually dropped the clinical because they felt that was giving more of a medical emphasis on applications, and it's not what they want. They want Research Time Awards. So it's for any healthcare professional. So we should be all specialties should be encouraged to apply for the Research Time Awards. They're released every year around about September, October time. They can help fund, I think it's up to 1 day a week for you to do your piece of research. So we need to be applying for them, and your R&D departments can help you apply for them. And the R&D directors can give you advice on how to apply for them. And in terms of other opportunities, if you are applying for grants like the RFPPB, which Sarah also mentioned, with her colleagues been successful, that's the Research for Public and Patient Benefit Award. It's released by Health and Care Research Wales around about every September, October time again. It's where you can apply for £230,000 over 2 years to fund a piece of research. Obviously, it's got to have a patient and public focus, and it must be NHS led. It's not HEI led. It's NHS led, but with partnership with a HEI or an academic partner and collaborator. So that's a really good grant, because they get fewer applications than NIHR or MRC grants, because it's just for NHS researchers in Wales. So that's a really good scheme as well that you should be thinking about. And they're not looking for you to cure cancer. They know that they're happy to fund pilot studies, feasibility studies, that will help find the evidence base for a much larger research grant in the future. So RFPPB is a really good call for healthcare professionals to submit their ideas to. So I've got 2 minutes left. I don't know whether there's any burning questions that anybody want to ask me. Hopefully you've enjoyed the session, and I'll just finish by saying we can do it. You're all experts in your own field. You've got a lot to offer in terms of research, and will you please think about what we've discussed today? I'm sure my presentation can be shared with all of you as part of the conference documentation, and go and talk to your R&D departments. There is a project out there in your specialty, in your field, that you could support. I am almost certain. So I'll say goodbye for now, and enjoy the rest of the conference. Thank you, folks, and thank you for your input. It was fantastic. It was excellent. Well done. Thank you.